Good evening, friends. So we start our centenary celebrations with today's talk, spectrum of bacteria and spectrum of antibiotics available. Why are we talking on this topic? Because as a family practitioner, we are guilty of, most of us, when we see a patient, when we examine a patient, when we hear a history, we just think of the medicine we are going to give. If we are giving antibiotic, we think of brand names. We never try to think of which organism may be causing this infection and which antibiotic is best suited. Many times, we may even write the brand that the last MR has come and told me that this works like magic and all that. So, although the speakers next 2 weeks, Dr. Suhas Prabhu and Dr. Rajiv Suman are going to mention the bacteria, I thought it is better for all of us if I do an introduction of what bacteria are there, what common ailments they cause, which are the antibiotics, and what do they treat. One important thing about these 5 webinars, at least today's webinar, please do not take notes. Please do not take snapshots, because this whole PPT as a PDF will be shared with you within half an hour on Telegram group. So those who are not on Telegram, I request to become a member there, because we really have wonderful interaction. Even I learn things at times. For the topic of infections and bacteria and antibiotics, I must expressly thank Dr. Aarti Mehta, who suggested antibiotics, and then I expanded on the whole topic and made it a 5-lecture series. Infection. What is an infection? It's an invasion in the body of a pathogen. And after invasion, if our immunity does not kill it, it is subsequent growth of the pathogen. And how the body reacts to that infectious agent and what toxins the agent produces is all called infection. The pathogens may be bacteria, viruses, yeast, fungi, or other microorganisms. Infection can begin anywhere in the body and either remain localized or spread all through the body. An infection may cause fever and other clinical problems depending on where it occurs in the body. An infection in the tonsils will cause pain in the throat. An infection in the larynx will cause hoarseness of voice, etc., etc., etc. So what are bacteria? Bacteria are small single-celled organisms. They are found almost everywhere on Earth and are vital to the planet's ecosystem, because other than causing infection, they are responsible for a lot of normal functions. And in the nature also, a lot of activities happen with bacteria. Some species of bacteria can live under extreme conditions of temperature and pressure. They can survive in the core of Earth, or they can survive in the nuclear waste also. We are full of bacteria, and it is estimated that we contain more bacterial cells than human cells. We contain almost 10 times more bacteria than our human cells. They come in various shapes. They can be spheres, circles, they can be rods, or they can be spirals. All bacteria are not bad. Common cell bacteria, we know good bacteria which we need for our body metabolism. They act on our immune system to induce protective responses that prevent colonization and invasion by pathogens. These bacteria work in two ways. They can either directly inhibit the growth of respiratory pathogens by producing antimicrobial products or signals and competing for nutrient and adhesion sites. There are adhesion sites which bacteria occupy and cause an infection. Our commensal bacteria can compete and block those sites. They're also known as normal flora. We know our skin has normal flora, our GI system has normal flora, which we replace through probiotic capsules. And we know that we are replacing almost 5 billion flora in one capsule. And all orifices, mouth, vagina, etc. There are over 1,000 types of commensal bacteria, whereas infective bacteria may be even 100. Now we talk of pathogenic bacteria. These are the bacteria that cause disease. The number of these pathogenic species in humans is less than 10. Bacterial pathogenesis, how do they cause disease? The infectivity of a bacteria results from a disturbance in the balance between the virulence or the negativity of the bacteria and resistance of the host. The objective of the bacteria, the aim of the bacteria is to multiply, not causing disease. Because it is in the best interest of the bacteria not to kill the host. As we know that viruses also, it is in the best interest of the virus not to kill the host, because a virus cannot survive without the host. A bacteria can still survive. Resistance to bacterial infection is enhanced by an intact immune system. Our immunity should be good. We should not be on immune suppressing drugs. We should not have diseases which cause immune suppression. And we should be having a good diet and a regular exercise. Initial resistance to the bacterial infection is non-specific mechanism. You know, specific mechanism of immunity is IgM, etc. Initially, our body resists by barriers. Barriers in the nose, barriers in the GI tract, barriers in the throat. Specific immunity, we know, develops over time, either through vaccines or through exposure to a disease. Susceptibility to some infection is higher in the very young and very elderly and in immunocompromised patients, because immunity in a newborn or a child, immunity takes few years to fully develop. And we know that the elderly have age-related immunity depletion. In today's talk, we are only talking of important bacteria. It's not a theory exam. We are only talking of important bacteria to us. The classification of bacteria is based on various criteria, such as nature of the cell wall. Is it rigid, thick wall? Is it flexible, thin wall? Or is there no wall? Then staining characteristic, gram positive, gram negative. Ability to grow in the presence of oxygen or without oxygen, aerobic, anaerobic. And ability to form spores, spore forming, non-spore forming. So what are the types of symptoms? Let us look at the symptoms before we look at the bacteria. One is a subclinical symptom. Patient has no symptom. It is detected accidentally. Asymptomatic gonorrhea and HIV. Latent infection is a carrier state commonly seen in typhoid. Accidental, inadvertent exposure. You may call even dengue is inadvertent, but dengue still, if you're not taking care of avoiding mosquitoes. Leptospirosis is very common for people who walk in the collected water, dirty water, and people who work in laboratories may get exposed to certain viruses or bacteria. Opportunistic is immune compromised, like pneumocystis carinii pneumonia and vaginal candidiasis. Primary infection is clinically apparent invasion of bacteria into a particular tissue and growth in that tissue. Shigella dysentery, a furuncle. Secondary infection is invasion subsequent to primary infection, where we have a bacterial pneumonia following immunity drop by COVID. Mixed, 2 or more microbes in the same tissue, anaerobic abscess showing E. coli and Bacteroides fragilis. The last one we do not see much often, but others we see very often in practice. Then there are acute infections, rapid onset, brief duration, like acute otitis media. Chronic infection, prolonged duration, may be in months and years, tuberculosis and leprosy. Localized infection, as the name suggests, a furuncle, a carbuncle, a boil, an abscess, ischiorectal abscess, generalized, disseminated to many body parts, septicemia or sepsis. Pathogenic, where pus is formed, staphylococcal, streptococcal, commonest are boils and abscess. And retrograde, where the organisms are ascending against the normal flow. UTI, urinary tract infection, giving rise to pyelonephritis. Urine travels as per gravity, whereas pyelonephritis, the bacteria are traveling upwards from the bladder or the ureter to the kidney. So let's come to the bacteria. First, I'm starting rigid, thick walls, free living. Free living means extracellular. Gram positive, cocci, staphylococcus and streptococcus. Staphylococcus causes abscess either in skin or other organs. You may get a pyogenic liver abscess. You may get a pyogenic lung abscess. And streptococcal, common infection we see in practice is pneumonia or pharyngitis. Then we have rigid, thick wall, free living, spore forming rods. Aerobic is Bacillus anthrax. We don't see it in practice. Anaerobic is Clostridium, tetanus, gas gangrene, and botulism. Non-spore forming rods could be filamentous and non-filamentous. Corynebacterium causes diphtheria and Listeria cause meningitis. Non-filamentous actinomyces cause actinomycosis and nocardia causes nocardiosis. It is complex for us to remember. That's why we are giving this PDF to you to store with you and refer as and when required. Then in the same free living, now we come to gram negative. Cocci, Neisseria, causing gonorrhea as well as meningitis, pathogenic meningitis. Rods, there is facultative and non-facultative. In facultative, we have straight respiratory organism Haemophilus causing meningitis, Bordetella causing whooping cough, and Legionella causing pneumonia. Although Legionella pneumonia is rare, but in every case of ARDS, before we diagnose viral, all these tests are done. Then we have zoonotic organisms. Brucella causes brucellosis. Yersinia pestis causes plague. Pasteurella causes cellulitis. And Francisella causes tularemia, although tularemia is not so common here. Then in facultative, we have curved rods. Campylobacter causes enterocolitis. Helicobacter we know causes gastritis and peptic ulcer. Vibrio causes cholera. In this, the aerobic ones, Pseudomonas causes pneumonia and UTI, more so in hospital-based patients, and anaerobic bacteroids causing peritonitis. Acid-fast Mycobacterium causing tuberculosis. Now, in rigid thick cell walls, but non-free living, so they have to be obligate intracellular. Outside the cell, they will die. Rickettsia causing typhus, Rocky Mountain spotted fever, and Q fever. We see typhus pretty commonly nowadays. And then we have chlamydia, which causes urethritis, trachoma, and psittacosis, which is actually a disease transmitted by parrots. Then till now we were seeing rigid thick walls. Now we have flexible thin walls known as spirochetes. Treponema causing syphilis, Borrelia causing Lyme disease, and Leptospira causing leptospirosis. Wall-less cells, rigid thick walls, flexible thin walls, and now no walls. Mycoplasma causing pneumonia. This is a chart of normal flora we have in our body, various species, and what are the anatomic locations. I will not read this out. You will have this to refer. You can refer it if you are wondering of something. Now we come to antibiotics. First group is penicillin. Those of us who are 60, 65 plus will remember in the earlier parts of our practice when we didn't have so many drugs, penicillin worked wonders. A GP who used penicillin injection had the largest practice because right from respiratory to skin, everything responded to penicillin. So now we have various brands, amoxicillin, not brand, sorry, generic, amoxicillin, ampicillin, carbanicillin, diclofenac, penicillin G, penicillin V are oral. Piperacillin is an injectable, ticarcillin is injectable. Two common combinations we see in practice or we use is amoxicillin clavulinate and amoxicillin dicloxacillin. Then injectable we have ampicillin, sulbactam, piperacillin, tazobactam, and ticarcillin plus clavulinate. Now, remember one thing, a point which I'm going to highlight later on. All these can be labeled as cousins of each other. It is not a new antibiotic. The common uses are wide range of infections, including streptococcal, enterococcal, Lyme disease, dicloxacillin along with amoxicillin or ampicillin used to treat staph infection. Not used alone, it is generally in combination of amoxicillin or ampicillin. Common adverse effects are GI upset, nausea, vomiting, rash in those allergic to penicillins. But oral penicillins generally are not known to cause anaphylaxis. Then we have what are commonly known as quinolones or fluoroquinolones. We have norfloxacin, ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin, gemifloxacin, and a gatifloxacin, which is only eye drops. Again, doctors who are, I would say, 60 plus or 55 plus will remember we had a Dombivli fever in Bombay, suburb of Bombay. It was a typhoid fever which was not responding to chloramphenicol. That was the time ciprofloxacin came in market and it suppressed that endemic of Dombivli fever. A lot of people died in that. Then what happened? The disease that we suffer from, irrational use of antibiotics. Pharma industry promoted Cipro like nobody's business. And today, norfloxacin does not work. Cipro hardly works. So what is given in black, common uses? Diarrhea due to certain bacteria and UTI, norfloxacin, ciprofloxacin, ofloxacin. Levo and moxi we use in pneumonia, prostatitis, and second line anti-tuberculosis treatment. Common side effects remain the same: GI upset, rash in those allergic to quinolones, numbness, and very rarely arrhythmia if the patient is diabetic or a heart disease patient. Macrolides. Azithromycin has become a common household name, consumed by people all over. Azithromycin is used for chlamydial infection of the genitourinary organ and urinary tract. Clarithromycin, erythro, and roxithromycin, respiratory infections, mycoplasma, streptococcal, throat infections. Common adverse effect: abdominal pain, nausea, vomiting, and diarrhea, especially at higher doses, rarely arrhythmia. Coming to cephalosporins. Cephalosporins form a mainstay of our antibiotic prescription today. There are 5-generation cephalosporins: cephadroxil, cephalexin, cefazolin were generation 1, mainly respiratory, skin and soft tissue infections, and pre-surgical prophylaxis. Most commonly, before you went for a dental extraction, they'll give you for 2-3 days. Side effects are same: GI upset, nausea, vomiting, diarrhea, allergy in those allergic to penicillin. Cephalexin we still use at times. Cephadroxil is not freely available. Cephalosporin second generation, cefaclor, cefprozil, cefuroxime. Respiratory infections, the side effects remain the same. Here, cefuroxime we use quite often nowadays. Third generation, cefixime, very commonly used. Cefpodoxime, again commonly used with or without clavulanic acid. You have a combination of cefixime with dicloxacillin also. Cefdinir, since it is a rare brand, I have given the brand name of AdSafe, Cefotaxime Omnisafe, and there are 3 injectables which we generally you don't use. They're used in hospitals, mainly respiratory, skin, and soft tissue infection. So you can say that they're kind of broad spectrum, mild to moderate infections. 4th generation is Cefepime, which we do not use often. Pseudomonas infection, most of the time we are treating without a culture, and Pseudomonas generally we never come to think of. Used in immunocompromised patients, resistant to other antibiotics. Side effects of all cephalosporins are common: GI upset, nausea, vomiting, diarrhea, allergy. And cephalosporin 5th generation is not available in India. It is ceftaroline injectable form. It is used for MRSA, methicillin resistant Staph aureus and Enterococcus faecalis. GI upset, nausea, vomiting, diarrhea, allergy. Rifamycins now. Rifamycins can be divided into 2 categories. One is rifabutin, rifampin or rifampicin, and rifapentine, used in combination with other antibiotic or other drugs to treat tuberculosis and related mycobacterium infections. Common adverse effects are rash, liver dysfunction, GI upset. We know that every time we give rifampicin, we have to tell patient to be cautious about red color, discoloration of saliva, sweat, tears, urine, and soft contact lenses. Even contact lenses get colored. And if you give rifampicin and patient says no discoloration, that is a fake drug. It has interaction with many drugs, often requiring changes in dose, commonest being oral contraceptive and rifampicin. Then we have rifaximin for diarrhea. This drug is hardly absorbed. It only affects in the gut. That is why it is safe in pregnancy and safe in lactation. Side effects are GI upset, nausea, vomiting, diarrhea, and flatulence. Sulfonamides. Although some of them are still available and very few of us use them, but I am a very good user of sulfamethoxazole trimethoprim. Skin infections that may be resistant to other antibiotics, including methicillin resistant staph, MRSA. I use it exclusively for Whitlow. Nail bed infection, I make glycerin maxel in my clinic. We give glycerin maxel poultice and we give combination of trimethoprim sulfamethoxazole. It works wonders. It works better than cephalosporins. GI upset, nausea, vomiting, you don't get often. Allergic rash in those who are allergic to sulfa. Very rarely it may cause leukopenia or thrombocytopenia. Sulfacetamide is a common eye infection available in drops only, and sulfasalazine is used for inflammatory bowel disease, more likely Crohn's disease. A caution: sulfonamide should be used during pregnancy only when the benefit of treatment outweigh the risk. However, they should not be used when the due date is near, because taken at that time, they may cause jaundice in the newborn. It may be severe enough to cause brain damage called kernicterus. The brain melts and it is yellow in color in the newborn. Tetracyclines, yes. Doxycycline we are still using. We may not be using tetra. Tetra, doxy, and minocycline. Common uses: acne, syphilis, chlamydial infections, Lyme disease, mycoplasma, rickettsial infection. We use doxy a lot in COVID. Skin infections caused by susceptible bacteria that are resistant to other antibiotics, including MRSA. Doxycycline is one antibiotic which is safe for long term. We are given as long as 3 months to 4 months in acne or dandruff related acne on the back. Of course, you start with twice a day, then make it once a day, then make it alternate day, and it still works. Common adverse infections are GI upset, Clostridioides difficile induced diarrhea, fungal infection with yeast candida, staining of teeth in the fetus if used late in pregnancy, and if you use in children below 8 years, then there is yellowness of the teeth. Aminoglycosides, only injectable available. They are a class of antibiotics used to treat serious bacterial infections such as those caused by gram-negative bacteria, especially Pseudomonas. In earlier days in hospital, the commonest combination was ampicillin-amikacin. We have amikacin, we have gentamicin, we have neomycin. Neomycin is available in topical as well as oral form. Amikacin, gentamicin are injections only. Amikacin, gentamicin are used for infection caused by gram-negative bacteria such as Pseudomonas, E. coli, and Klebsiella. Kanamycin, streptomycin are used for tuberculosis with other drugs, mainly second and third line of tuberculosis and AKT. Tobramycin is eye drop used for eye infections. Common adverse effects: hearing loss, dizziness, and postural hypotension. Oxazolidonins, very nice antibiotic. I'm happy that it is still not come under abuse. They're a class of antibiotics used to treat serious infections, often after other antibiotics fail. I personally use it after drugs like amoxicillin, clavulanic acid have not worked. Linezolid, serious infection caused by susceptible gram-positive bacteria, staph, including MRSA, streptoenterococci, including vancomycin-resistant enterococci. Now understand, if your stool culture shows vancomycin resistance, your linezolid is going to work. GI upset, anemia, leukopenia, TCP, peripheral neuropathy, visual disturbances. Normally, if you are giving for 5 to 10 days, we generally do not do a CBC or anything. Now, the reason of this 5 webinar series, rational use of antibiotics. What was the last antibiotic discovered? After nearly 30 years, a new antibiotic was discovered. Otherwise, we were just discovering first cousins. Teixobactin was hailed as a game changer when it was discovered in 2015. So when you say 30 years from 1985, we have not had a single new antibiotic. Due to its ability to kill multi-drug resistant bacteria, what we call as a superbug, such as MRSA, without developing resistance. In 2015, they said if it is made suitable for humans, it would mark the first new class of antibiotic drug for 30 years. And now, in June 2020, scientists have taken another step forward on their quest to develop a viable drug based on Teixobactin, a new class of potent natural antibiotic capable of killing superbugs. I'm happy it's not yet available in commercial market. Otherwise, we will have resistance to this also. Why should we not do injudicious use? You know, if our mind says no, dekh lete hain, let me see after giving, then that is injustice to the patient. Antibiotic resistance is an increasingly serious problem globally. One of the causes is the injudicious prescribing of antibiotics for self-limited viral infections. Antibiotics do not have a preventive role. A lot of patients, millions of them in COVID, have been given meropenem. We physicians often cite parent and patient pressure as factors in our decision to prescribe antibiotics for viral URTI? Doctor, please make him all right. He can't afford to miss school. Patient education on completing full course if prescribed. This we have to always target. Please do not stop midway because that itself can cause resistance. No antibiotics on their own. We should always keep harping. Educational efforts aimed at both physicians and patients hold the most promise in decreasing unnecessary antibiotic use. We have to realize and accept that patient satisfaction is generally linked much more to communication than to writing of a prescription. If you have a practice where you have barely 2 minutes to talk to a patient, you will write more of injudiciously antibiotic because you don't have time. Then this reference was again shared by Dr. Aarti Mehta with us. So I thought I must share with you. Antibiotic use disrupts our immune system. Patients prescribed antibiotics in hospitals because they're always given higher antibiotics are more likely to get fungal infections because of disruption of the immune system in the gut. The life-threatening systemic fungal infections, not topical, not local, invasive candidiasis, esophageal, intestinal, is a major complication for hospitalized patients who are given antibiotics to prevent sepsis and other bacterial infection. And hospitalized patients generally have low immunity. Fungal infections we know are more difficult to treat than bacterial infections. Okay, this is the repeat of the same thing. What is our duty? Findings demonstrate the possible consequence of using antibiotic in patients who are at risk of developing fungal infection. So if I'm giving an antibiotic, even justified for URTI or LRTI, uncontrolled diabetic, patient on oral steroids, disease modifying drugs, I have to be extra careful. I have to think and I have to keep on a watch for fungal infections. If we limit or change how we prescribe antibiotics, we can help reduce the number of people who become very ill from these additional infections. You know what happens is, if I have given an antibiotic injudiciously to a patient whose sugar was 400, we never ask for blood sugar while prescribing antibiotics. And this patient gets a systemic fungal infection. I will not even realize, I will just think that antibiotic was not strong enough for the infection. That is all. Somebody asked the question, how will PDF be shared? PDF will be shared only on Telegram. Should we use second-line TB drugs for general resistance to disease as it would be catastrophic? No, we should not use unless we have a culture done, unless we have a gene expert telling us there is a resistance to Rifamycin. So those who are on Telegram, we will give this table of antibiotics and bacteria. So I request all of you to please circulate about these webinars, because we very rarely get such good speakers and a very burning topic of irrational use of antibiotics. So today there are no questions. Have a nice evening. Thank you very much. Preeti, make sure that everybody's added. And I request all
Yes,
of you to use Telegram group discussions, but always give a detailed of the history that you are showing, not just snippets. Thank you very much.